Good morning, good afternoon, and good evening to our DCVMN conference. I'd also like to say welcome to all of you to Cape Town, where BioVac is located. And through the invitation, you may have seen our very beautiful Table Mountain. Please keep that image for the next 3 days because the mountain still exists. I saw it as I drove through to work this morning, and I promise you it looks exactly the way it is on the picture. So just picture that you're in Cape Town for the next 3 days, please. And we will make sure that we keep the city as beautiful as it is for your next physical visit. But for these next 3 days, we assume that you will be here. My name is Mrna Vaccines. I'm the Chief Executive Officer of BioVac, which has been a long-standing member of the Developing Country Vaccine Manufacturing Network. I'm also proud that our company is a co-host this year. It's extremely unfortunate that we could not hold a face-to-face meeting in our country and in our city and in our company. However, we will try and make the best use of it together with the organizing committee. Having said that, we're also very proud to not only be a long-standing member, but to be active in even current matters that are related to the pandemic, which I'm sure are going to dominate a lot of our discussions going forward. Sai is going to introduce our Honorable Minister of Higher Education, Science and Innovation. But whilst he does the formal introduction, I'd just like to preempt and say that our minister is one that is not only just coming with a ministerial hat here on behalf of the president, but also is somebody that knows this industry very well since he took on his portfolio. He knows it not only from a pandemic perspective, but even prior in investing time and effort in visiting the likes of BioVac. We've been engaging him. He's been a champion of vaccine in the industry. And his portfolio also includes being busy with universities. So as you're going to hear him, he's somebody that is really invested in time, effort, and I can vouch very much for that myself. And I'm very excited that he's. On that note, then, I hope that we're going to have a very successful 3 days. And looking forward to many of the engagements. I'll hand over to our president, being Sai Prasad.
Thank you, Mrna. I do feel bad that I couldn't travel to Cape Town for this exciting meeting. It would have been great to be meeting in person and having these interactions in person. But we are doing the next best thing. I think the knowledge sharing and the information sharing will be real. Except we just can't be with each other face to face. Thank you, Mrna. Thank you, BioVac, for hosting this 22nd AGM of the Developing Countries Vaccine Manufacturers Network. I'm Sai Prasad. I'm the president of the DCVM. And recently, we've also changed our constitution into a board. And so thereby, I'm the chairperson of the board for the DCVMN. I take this opportunity to invite everybody for this AGM. It's an honor and a pleasure to have you in the audience for this important meeting where we get to present all the good work developing countries and developing countries vaccine manufacturers have been doing to fight this pandemic. Without further ado, I'd like to take this opportunity to introduce His Excellency, Dr. Nazim Ande, Minister for Science, Technology and Innovation in South Africa. And what is very appropriate is that the concept of science, technology and innovation, especially in South Africa, it has really taken shape now with under the leadership of the Honorable Minister. You know, companies like BioVac and Aspen Biopharma are at the forefront in developing vaccines or manufacturing vaccines to protect against this pandemic. Without further ado, I would request the Honorable Minister to provide his inaugural address. Thank you.
Thank you very much to the moderators, Dr. Mrna Vaccines, the CEO of BioVac, and Mr. Sai Prasad, the board chair of Developing Country Vaccine Manufacturers Network, Dr. Ghebreyesus, the Director General of the World Health Organization, and your team members, Dr. Seth Berkley, CEO of the Gavi Vaccine Alliance, Dr. Richard Hatchett, the CEO at Coalition for Epidemic Preparedness for Innovation, all panelists and other distant guests, ladies and gentlemen, members of the media, I greet you all. Let me start by taking this opportunity to thank the organizing committee under the leadership of the CEO, Mr. Suri, for successfully putting this event together under challenging circumstances. The coronavirus pandemic has not only led to the untimely death of millions of people around the world, but has also destroyed a lot of livelihoods. It gives me a sense of pride, though, and excitement to give an inaugural address in this important meeting today, held under the theme Vaccines, New Challenges, New Paradigms, New Opportunities. First, as developing countries, we are taking the matter of vaccine manufacturing seriously, having learned, if not from the past pandemics, but definitely now from COVID-19 experience. The greatest lesson we have learned from this pandemic is that those with better health systems have done better. This is amongst the reasons why South Africa supports the establishment of a global health financial intermediary fund for pandemic preparedness, as well as a global health threats council. It open meeting could plan on how developing countries would be supported, not only to meet targets around vaccinations, oxygen diagnostic, personal protective equipment, but also for manufacturing. We must close the financing and supply gap for COVAX, AVAT, and other mechanisms. Cooperation, corrective action, and above all, consensus is our greatest strength in the current crisis and will continue to be so in the future. I'm also proud that BioVac, as one of our pioneering vaccine manufacturers, is co-hosting this event. It is pleasing to note that BioVac has been a long-standing member of DCVMN and is part of the executive committee. BioVac last hosted a similar meeting in 2007 in Cape Town, and this is the host. I would like to thank Mrna of VMN. Ladies and gentlemen, the fact that the Developing Country Vaccine Manufacturers Network is one of the largest vaccine industry associations, which enjoys a membership of over 40 companies from 14 countries, including South Africa, Brazil, Argentina, Indonesia, China, and South Korea, shows that developing countries can work together to build strong vaccine manufacturing capabilities on their own. One of the biggest challenges we face with the current pandemic is that while many in developed countries are vaccinated, we in the developing world are still waiting for vaccines, largely. As of yesterday, 3.75 billion people worldwide have received a dose of COVID-19 vaccine, which is equivalent to 49% of the world's population. About 77% of these have gone into the arms of those middle class. This is definitely unjust and immoral. It is apparent that the gulf is widening between better resource countries who are buying up and even hoarding vaccines whilst developing countries are struggling to have access to vaccines at all. Most countries are still dependent on vaccine sharing arrangements under COVAX, aiming to provide 2 billion doses by the end of 2021. We are, however, concerned that we may even get far much less due to production problems, export bans, and vaccine apartheid, if one can use that phrase. Whilst we welcome the donations and sharing of vaccines with developing countries, such countries should be able to manufacture their own vaccines as well as with you of ensuring we can sign an agreement through the Africa Vaccine Acquisition Task Team to gain access to at least 220 million doses of Johnson & Johnson vaccine. The DCVMN must therefore, working in partnership with governments, position developing countries to deal with emerging pandemics better. Science, in any case, is already telling us that we have indeed entered the age of pandemics. I'm pleased to say that South Africa, under the leadership of President Ramaphosa, is not only spearheading efforts to access COVID-19 vaccines for South Africa and the continent at large, but is also leading a program of local vaccine manufacturers by South Africa of the mRNA vaccine technology transfer hub through Afrigen and BioVac, and our government support of this initiative shows that we are committed to working together with fellow developing countries towards breaking dependence. It is therefore timely for an African company to be hosting a vaccine summit, especially because we need to deal with this undesirable situation of being the last continent to receive COVID-19 vaccines or any other health-related technology solution for that matter. With an association such as the DCVMN, we do indeed consider ourselves in a company of those who are keen to establish support systems for the African continent. We indeed pride ourselves in those developing countries that are contributing to COVID-19 vaccines, such as the Serum Institute of India, producing the Oxford AstraZeneca vaccine, Biological E from India, producing on behalf of J&J, Aspen in South Africa, which is also producing for J&J, and soon BioVac South Africa, which will be producing the Pfizer vaccine, amongst others. Of course, companies that have a special mention on this platform. They are Sinovac from China, Bharat Biotech, and Zydus Cadila from India. We can, with this capacity, build our own capacity to foster technology transfer programs. As South Africa, we are really confident about this possibility. Let me also acknowledge those DCVMN members that are part of the World Health Organization network through the mRNA hubs, such as various South African universities and the Pan American Health Organization, which has just announced the selection of Synergium Biotech in Argentina and Biomanguinhos in Brazil as regional hubs for the development and production of mRNA-based vaccines in Latin America. Having learned from COVID-19 and still celebrating World Health Organization's last week important announcement of the approval of the use of the first malaria vaccine, we are proud to hear that this vaccine will be produced by one of the DCVMN members, Bharat Biotech. This just shows the potential that we have. The development heaviest that must stone unturned in fostering and supporting more research to develop our own vaccines and drugs. I therefore take this opportunity to wish you all the best and look forward to fostering partnerships to work together to defeat COVID-19 and also build capacity to deal with future viruses. We're also looking forward to the outcomes, decisions, and important observations that will emerge from this gathering. I wish to thank you all.
Thank you. Thank you, Honorable Minister, Your Excellency. Thank you for that excellent inaugural address. And it sets the tone for what DCVMN and all our member organizations, companies are doing around the world. You started with what BioVac and Aspen are doing, and also the Serum Institute of India, Sinovac and Sinopharm, Biomanginos. So many companies are contributing in this work to fight against this pandemic. Thank you very much for that inaugural address. It's my honor and pleasure to introduce Dr. Tedros, the Secretary General of the WHO. He needs no introduction. He's been on the forefront on several aspects of this pandemic. And unfortunately, he's not able to join us in person. He does have a video feed for us. Thank you. Sonia, we're not able to hear the voice.
Not yet.
Just a second, please.
Is a triumph. Dear colleagues and friends, the development of not one, but several safe and effective vaccines against COVID-19 in record time is a triumph for science. But the shocking inequity in access to those vaccines is a failure for humanity. Know-how, data, technologies, licenses, and intellectual property remain in the hands of a few, leaving millions of people at risk. WHO continues to work with our partners to explore all avenues to rapidly scale up production in low and middle income countries, including technology transfer, voluntary licensing, and a waiver on intellectual property rights. We continue to urge the countries and companies that control the global supply of vaccines to join the WHO COVID-19 Technology Access Pool. WHO and our partners have also established an mRNA vaccine technology transfer hub in South Africa to facilitate the sharing of know-how, the scale-up of production. This problem is much older than COVID-19, and it will still be there after the pandemic unless we do something about it. It's clear that we need increased investment in local production capacity in all regions, together with enhanced regulatory systems for global health security. This is a key priority for WHO. The developing countries' vaccine manufacturing network is more important than ever for building that capacity. We look forward to our continued partnership to build a healthier, safer, fairer future for all people. I thank you.
Thank you, Dr. Tedros, for that very, very important message. And it is very important. You know, companies and industries, not just in the developing world, but also in the developed world, have done an excellent job of developing vaccines. But like you mentioned, it is not a success until these vaccines are available for all populations in every country of the world. I think with that, we know that our task is not fully done yet, and we have a lot of work to do. I'd like to take this opportunity to introduce Dr. Bruce Aylward, who is heading the ACT-A Accelerator at the WHO, and bringing together industry and organizations working for vaccines, diagnostics, and therapeutics.
Thank you very much, Sai. I just want to confirm first that I can be heard fine. Great. And to everyone present, I'd like to first just take the opportunity to reiterate the Director General of WHO's thanks for everything DCVM and members have done in the effort to try and accelerate the way out of this pandemic. I'd like to recognize your role in particular, Sai, as a member of the ACT Accelerator. And what I'd like to do is show a few slides, if I might, Sai, just to help set the stage for the deliberations in this opening session and subsequent ones, which lays out a little bit what the vision was at the outset of this pandemic in terms of trying to achieve equitable access, where we've arrived and what we have to do next. With that, Sai, I'm going to put up a couple of slides, and then what we can do is share these afterwards so members of DCVM all have a copy. If I could just confirm, Sai, that you can see on your screen?
Yep, I can see it.
Great. So folks, I've entitled this Cooperating to Control COVID-19 and the ACT Accelerator at 18 months. So first of all, in this alphabet soup of acronyms we use in the international development world, just to remind everyone, that stands for Access to COVID-19 Tools, a subject so close to our heart and that of DCVM and members. Also, so I'd just like to emphasize and thank the Honorable Minister for his excellent opening comments, which set so importantly the stage for the discussions of today. So we talked last year when the DCVMN last met about the ACT Accelerator and what it is and where it's headed. Let me talk a little bit now what's happened in that last 12 months and where we need to go next. So this is just a quick recap. On the left-hand side, for everyone in this audience already knows the devastating impact of COVID-19 with the cases, the deaths, and the global loss of revenues. You can see the big numbers on the left. And on the right-hand side, just a quick reminder for everyone that the purpose of the ACT Accelerator, when it was launched by the Director General and other luminaries, including, of course, the DCVMN and industry just 18 months ago, was to accelerate the development of the test treatments and vaccines, but even more importantly, that second bullet you see right at the very bottom, to ensure equitable access. Now, if we look at where we are today, the world has changed fundamentally in terms of our ability to tackle COVID-19 globally. And when we say the ACT Accelerator has done this, it's not the agencies that are at the heart of this and helping coordinate. It's really industry that has created so many of these tools and scaled them, and the scientific miracle that you've brought to bear, especially in the area of vaccines. But today, of course, we have vaccines that can prevent COVID anywhere. We're everywhere. We have tests that could detect these anywhere, and we have treatments that can save lives anywhere, and new treatments, as you know, in the pipeline, not always as easily accessible, but existing already. At the bottom, we've also created mechanisms to ensure the equitable uptake and use of these tools. However, those mechanisms that you see here only work if everyone participates in solidarity in the rollout. And that's not what's happened. Over the last 12 months, we had a great promise when, you'll remember, Sai, when we met here at the DCVMN last year, just rolling out vaccines, the data were coming in. It was such an exciting time. And we thought, great, we're going to vaccinate all the healthcare workers together. We're going to vaccinate all the older people together. And then we are going to move out of this pandemic, its worst impact. And of course, we didn't see that. What we saw instead were headlines like you see on this slide, which are the consequence of the inequitable rollout that His Excellency the Minister spoke of earlier. You've all seen these, you all know about these. More important now is what are we doing about this? Well, we're trying to bring the entire weight of the United Nations system to help address the issue of inequitable rollout, and especially in the area of vaccines. On the 7th of October, you can see pictures here from a press conference at which the Secretary General and the Director General together launched a new strategy to achieve global COVID-19 vaccination by mid-2022, and then sustain vaccination against COVID-19 viruses as needed through the foreseeable future. You can see on the bottom left, ambitious targets. Their goal was to vaccinate 10% of the population in every country by the end of September 2021. We missed that target in 56 countries. And that was because of a supply side problem, which makes, again, the DCVMN so crucial. It's a supply side problem. We are at risk of missing the 40% target in 80 countries by the end of this year because of primarily a supply side problem. And then the goal of June to reach 70% coverage or whatever the national targets, as high as they might be, and then sustain that also at risk. This brings us to the image you see on the right-hand side of this slide that lays out in the back of this strategy the role for everyone. We cannot achieve and sustain equitable access to these tools, and especially vaccines that anchor it, without DCVMN. So again, telling you things you already know, Sai, and everyone here, but I just want you to know the entire UN system is with you in this. If we look at where we go next in the ACT Accelerator, I want to start, if I might, ladies and gentlemen, with a couple of slides on our assessment at the World Health Organization and in the ACT Accelerator as to where we're headed in the COVID crisis. This has implications for your planning as manufacturers, not only what you do on COVID, but crucially, what we're doing on all the other vaccines that are so important to controlling diseases around the world. So first of all, let's be super clear on this slide, as most of this group is, the COVID crisis is not over. Despite this perceived return to normality in some parts of the world, transmission and mortality remain high. This is most striking when you look at the circles on the right-hand side. If you look at the top, this is the daily rate of COVID deaths in October of last year. This was the month before we met here in DCVMN last year, and you'll see 6,000 deaths a day. Look at the situation at the bottom of this graphic. We're at 8,000 deaths a day, or 7,000 right now. So the disease has not gone away. Mortality has not gone away, even though vaccine coverage has gone up. And there's a mix of reasons for that, right? Part of it is how people are or are not applying public health and social measures as vaccine coverage goes up. But the other big part of it, of course, is the problem of inequity. And then finally, the virus itself. So let me say a word about the virus, because again, this has implications, of course, for your planning as manufacturers and our joint role in getting out of this crisis. So we're dealing obviously with an evolving virus. And I like to show this simple slide here on the left to help audiences understand that these new variants have big implications for vaccine because they're challenging herd immunity. That graph you see, that curve shows you our famous thinking about herd immunity thresholds. And the original virus, of course, was on the left-hand side of that curve, suggesting that when we got to a certain level of coverage, given the basic reproductive rate and the vaccine effectiveness, we could achieve herd immunity. With the Delta virus, this has changed because you can see here the Delta virus lies a little bit to the left, which means we could have sustained transmission into the foreseeable future which means we need very high coverage with this vaccine to protect population. We need to sustain it, and we need to use other tools. You can see here this full package of tools, crucial, but vaccines, we need to be thinking higher coverage, more people, faster, and for longer. Now, the second problem, though, is I mentioned the virus in terms of the epidemiologic picture we're seeing, but the second problem, again, it's been highlighted by all the speakers so far, is the escalating inequity. It's so easy to use the word, but this graphic shows you how grave the situation is. Any of the countries in any color other than green are a long way from getting to the levels of immunity, vaccine-induced immunity needed to reduce their mortality rates and burden of disease. You can see whole continents are not where they need to be, nor able to sustain it. A lot of people challenge that and say, yes, but they don't have a lot of disease. And that's why I put in the slide, the panel at the bottom for this audience. So you can see, you can barely see, if you look on the left-hand side, low-income countries, extremely low testing rate, low middle-income countries, very low testing rates. As a result, we don't even properly understand the evolving epidemiology in those areas. But both problems have to be solved. If we can't solve these inequities, if they continue, ladies and gentlemen, we estimate at least 5 million additional lives would be lost in 2022, completely preventable. 5.3 trillion would be lost in economic output by 2026. That number comes from the World Economic Outlook from the IMF just a few days ago. Now, the ACT Accelerator is crucial to solving this inequity problem, because if we just focus for a moment at the part of the map that is red or yellow, and we look to this next slide that I'll show you, those are a lot of the countries on the rightmost column in the panel on the left. So if you look at those columns on the left-hand side, you can see the low-income countries, LICs, and with the most color, you can see 80% of the vaccines that these countries have used, even though they are very low coverage levels, has come from COVAX, which means COVAX is so important to solving the inequity problem. We can't overstate that. And what we really need is the cooperation of manufacturers, of course, completely with COVAX, because that is what is solving the inequity problem, not the bilateral deals, which you see in gray. So a crucial piece of this for both low and low middle income countries increasingly. Also on the diagnostic side, you can see on the right-hand side, but I'll scoot past that in the interest of time. So the ACT Accelerator has a crucial contribution role to the global targets for controlling COVID-19 over the next 12 months. You can see in the areas of vaccines, diagnostics, et cetera, we've laid out very crucial roles that the ACT Accelerator will play. And we have summarized all of this now in a new ACT Accelerator strategic plan and budget. And thanks to you, Cy, and the DCVM members who've been part of the consultative process to get us there. It has ambitious equity targets. You see a cover of the draft consultation version of the plan on the left-hand side. We will launch this next week with its $22 billion budget to try and address exactly the challenge that the minister highlighted, solving inequity in the next phase of the ACT Accelerator. All of this in the run-up to the G20 summit. My last slide, just to summarize some of the points we've made today and set the stage for the remainder of the discussion of this opening session. If equitable access to COVID-19 tools continues, lives lost, revenues lost are absolutely huge and unacceptable. ACT Accelerator, as you've seen in that bar graph I just showed you, crucial role in solving the inequity, especially through our COVAX pillar, which our Gavi colleagues and SEPI and others will speak to in a moment. The cost of that is high, but the monthly economic costs right now, the world are bearing 4 times the entire ACT-A budget, just to put everything in perspective. The last point, it's self-evident to everybody in this group. You are absolutely crucial, central part of the ACT Accelerator, and there is simply no way, Sai, as you well know better than anyone, we are going to solve global inequity in access and sustain it in the longer term without DCVMN. So as we go forward in all of those areas which the minister highlighted and the Director General of WHO, everything from how we distribute vaccines to where they are made, you are seeing the ACT Accelerator, its partners, and the World Health Organization leaning right in to try and help you in the important role you play in this crisis and others we will face in future. Thank you, Sai.
Thank you, Bruce, for that excellent keynote address. I think you've hit all the points in the right stride. I've known you for 20 years, and you bring the same amount of zeal, zest, and enthusiasm that you had for global polio eradication to Act A. And knowing from your past work, I have no doubts that we will also be very successful in this. To respond to a quick set of points, DCVMN manufacturers already are supplying almost 50% of, they're manufacturing, almost 50% of the global supplies now. And this is set to increase even more in the months to come as more manufacturers get EULs and more manufacturers are able to supply. And I think you will see a very big difference in the amount of contributions from several manufacturers, not just from China and India, but from Indonesia, from Brazil, from South Africa, as you heard. I think that's where the future is going to, and the future does look good. We just need to accelerate it. I think we just need to accelerate it. That's the message from the Honorable Minister. That's the message from the Secretary General, and that's the message from you also. With that, thank you, Bruce. I take this opportunity to introduce Dr. Seth Berkley. Dr. Berkley, or Seth as I personally call him, needs no introduction for this audience. He has taken a real leadership role with the establishment of COVAX. Gavi has already been doing an excellent job in low-income countries and lower middle-income countries. But with the establishment of COVAX, I think it's really a game-changing situation for many of these countries. And it's not just the low and middle income countries, it's also several middle income countries and certain high income countries that are also participating in COVAX, which shows the power of Gavi and a mechanism such as Gavi. I mean, it is an idea that was 25 years ago, but today we can see it in action and it has been extremely successful. With that, I request the organizers to play the video from Dr. Berkley. Thank you.
It's really great to be here to celebrate with you the deepening of the relationship between Gavi and DCVM member companies. Over the last 21 years, Gavi has been able to reach approximately 900 million children with a growing range of vaccines, preventing more than 15 million deaths. We have reduced vaccine-preventable diseases by 70% and reached more than half of the world's children. In our last 5-year strategic period between 2016 and 2020, Gavi helped countries immunize 324 million unique children and averted 6.9 million future deaths, exceeding our target of 300 million immunized and 5 to 6 million deaths averted. This was only possible thanks to a supplier base that has continually evolved. From an original 5 suppliers, including 1 DCVM, to 18 suppliers in 2021, with more than half of them based in Africa, Asia, and Latin America. The investments made by DCVM manufacturers in R&D, production capabilities, and quality assurance have been critical to ensuring that supply meets the growing demand of Gavi-supported countries, that program-suitable vaccines at affordable prices are available to these countries, and that supply security is improved. For example, from 2012 to 2020, DCVM supplied over 50% of the vaccines for Gavi-supported countries. The volumes for 2020 alone are approximately 300 million doses. In 4 vaccine markets, DCVMs are now the sole suppliers for Gavi-supported countries: Japanese encephalitis, measles, rubella, meningococcal A conjugate, and typhoid conjugate vaccines. And finally, working with you, the cost to immunize a child with penta, rota, and pneumococcal vaccines has decreased by 57% through the competitiveness and innovation of the work you're doing. These figures are a testament to how essential DCVM manufacturers have become to the Gavi Alliance model. DCVM manufacturers are also playing an increasingly important role in global health by improving the access of non-Gavi countries to safe and affordable vaccines. The biggest example is the recent efforts of DCVMs in the fight against COVID-19. The speed at which DCVM suppliers started working on in-house R&D projects and building partnerships with other manufacturers and research organizations to develop and produce COVID-19 vaccines are proof of their commitment to global health. Their success is critical in the fight against COVID-19. Gavi is at the center of the international response against COVID-19, founding and coordinating COVAX with the Coalition for Epidemic Preparedness Innovation, CEPI, WHO, and UNICEF. Involving more than 190 economies representing more than 90% of the global population, COVAX is an unprecedented example of global solidarity. Born out of necessity, it is a global solution to a global pandemic with the singular goal of ensuring rapid, fair, and equitable access to COVID-19 vaccines for people all across the world, regardless of their ability to pay. In order to access early doses and ensure affordable prices, COVAX relied on a longtime partner and the largest vaccine manufacturer in the world, the Serum Institute of India, which is a DCVM member. Unfortunately, after starting off strong with vaccines available at a record 39 days after the first dose injected in a routine program in the world, vaccine nationalism meant that doses stopped being shared, which has led to great inequities in vaccine supply. This has forced us to further diversify. The COVAX facility is in discussion with both existing and potential manufacturers of COVID-19 vaccines, including DCVMs, to continue building a diverse portfolio with the goal to access multiple vaccines and to account for risks of R&D failure, regulatory hurdles, programmatic suitability, and supply constraints. We've already allocated 818 million doses and delivered 371 million doses in 144 countries. This is faster in a larger number of countries than ever before in a pandemic. Looking forward to Gavi's next strategic period, our vision is to leave no one behind with immunization, and our mission is to save lives and protect health by increasing equitable and sustainable use of vaccines. In order to achieve these ambitious goals, it's critical that vaccine markets continue to evolve towards healthier states and that manufacturers continue to invest in the development of innovative vaccines and immunization-related products. This can only be possible with continued support and contribution from DCVM member companies. Specifically, we are following the development of multiple vaccine candidates and other innovations in the pipeline of DCVM member companies in Gavi-supported categories such as HPV, PCV, hexavalent, multivalent meningococcal, and TCV, just to name a few. And we welcome their future market entries, such as hopefully malaria and tuberculosis. Finally, Gavi welcomes initiatives that can contribute to a diversified global supply base to improve supply security, including diversification in the form of manufacturers under the oversight of a range of country regulatory agencies. From this perspective, Gavi recognizes the political momentum to establish vaccine manufacturing capacity in Africa and the potential economic and self-reliance opportunities presented by such initiatives. It is clear it is an endeavor that will take a number of years and will require dedicated and sustained financing, resources, and political will. Although the Gavi model is agnostic to the location of manufacturers, which of course there is a caveat that we do favor geographic and NRA diversity within any given market, Gavi is willing to partner in understanding how African manufacturing could contribute to supply security, innovation, and affordability for vaccines. Gavi remains committed to supporting DCVM manufacturers as core members of the alliance in their efforts to help us achieve our collective and very noble goals. Thank you so much for listening.
Thank you, Seth, for that excellent overview of how DCVM manufacturers have been assisting Gavi and UNICEF and PAHO in the fight against our traditional vaccines for routine immunization, but also how we are able to deploy that knowledge that we have learned in terms of product development, R&D, and large-scale manufacturing from vaccines for routine immunization to COVID-19 vaccines. And if, to the audience, if Gavi represents, the pull mechanism for vaccines, the push for this mechanism comes from CEPI. CEPI is an integral part of the Gavi, the COVAX facility, and CEPI has been at the forefront in encouraging product development and research and development for epidemic vaccines and also the current COVID-19 vaccines for the current COVID-19 pandemic. With that, I would like to take this opportunity to introduce Dr. Richard Hatchett, the CEO of CEPI, to give us his keynote address. Thank you.
Your Excellencies, Minister Nzimande, Director General Dr. Tedros, Dr. Makwana, Mr. Prasad, colleagues, friends, I'm delighted to join you today for this inaugural session, and sorry that I cannot be with you in person in Cape Town this morning. I extend my warmest greetings and wish you all a successful and productive 22nd Annual General Meeting. I hope that we can all gather together in person in a year's time. New challenges, new paradigms, new opportunities. This is an apt summary of our scientific journey over the last 22 months. It is also remarkably hopeful, which on the surface of it is surprising. Not a single one of you would disagree that our experience of the pandemic has been dreadful. The benefits of our ingenuity, however, are perhaps nowhere better demonstrated than in our vaccines, which have been developed at unprecedented speed and now are being delivered at scale. More than 30 have reached phase 3 clinical trials, and many have been licensed. Some 6.6 billion doses have been delivered. For the countries that have access, the vaccines are nearly a deliverance. People in such countries have emerged from their shelters and are asking themselves if it is over. But the inequity of the vaccine's distribution is nearly unbearable. As of last week, more people had been fully vaccinated in Switzerland, or in Singapore, or in Hong Kong than in Nigeria, Niger, Cameroon, Chad, the Central African Republic, the Democratic Republic of the Congo, Ethiopia, Somalia, Sudan, and South Sudan combined. This is a bitterness that will linger in the mouths and memories of hundreds of millions of people long after the pandemic subsides. So it is remarkable to attend a conference, especially one hosted on the African continent, with such a hope-filled title. And what is even more remarkable is that that hope seems fully warranted. Yes, until now in the pandemic, despite our best collective efforts, things have played out more or less as they have always played out, with searing unfairness and injustice. But we have also witnessed a miracle of science in the speed with which new and highly effective vaccines across many different platforms have been developed, in the speed with which manufacturers have scaled their production, and in the speed with which they are being distributed. We are truly entering a new era. From CEPI's vantage point, we see at least 6 major positives emerging from the pandemic that make us hopeful. First and foremost are the advances in technology, not just in terms of the new vaccine platforms, new approaches to the use of mRNA, for example, or new viral vectors, or new innovations in manufacturing, but also the revolution in the underlying vaccinology, advances in terms of immunogen design, immunobiology, rapid sequencing, and the rapid publication of results. This is the scientific core that enables everything else. Second are the cumulative innovations across many different vaccine programs and different regulators that helped speed vaccines through the clinical development, manufacturing scale-up, and regulatory processes. We are working with McKinsey now to collect a global catalog of these innovations, which we believe will help us dramatically accelerate vaccine development in the future and help us identify areas where focused effort can produce additional acceleration without jeopardizing assessments of safety or efficacy. Many of these will be translatable to other areas of product development. Third are the new concepts of preparedness that have been validated during the course of the pandemic. The work of Barney Graham and colleagues at the US National Institute for Allergy and Infectious Diseases Vaccine Research Center to articulate and then, through the response to COVID-19, demonstrate the value of focusing on so-called prototype pathogens to prospectively solve the problems of vaccine design for different viral families proved itself brilliantly when he and Jason McClellan designed what became the Mrna vaccine within 48 hours of the viral sequences being released. This is nothing short of astounding, and it sets a benchmark for all future responses. We now need to extend this work to other viral families that present a threat to humanity. This will take substantial resources, of course, but it is a finite problem, and many major funders are already buying in conceptually and intellectually to the approach. Fourth are the new institutional arrangements and multi-sectoral partnerships represented by efforts such as the Access to COVID-19 Tools, or ACT, accelerator, COVAX, and the emerging partnership between WHO, the IMF, the World Bank, and the World Trade Organization. We will likely see more such novelties as the G20 and G7 reach conclusions about new financing arrangements and governance and monitoring mechanisms and contemplate the pros and cons of a proposed pandemic treaty. We can anticipate that international meetings in the months ahead will fundamentally alter the international preparedness and response architecture, analogous to the way the Bretton Woods Conference in 1944 triggered the creation of new international monetary system and institutional order in the wake of World War II. Fifth, and crucial, are the emergence of new regional mutual security partnerships. These have been especially notable in Europe and Africa, where collective purchase arrangements have been implemented, and regional entities such as HERA and Africa CDC and AVAT have either been created de novo or grown in stature through the response to the pandemic. It seems almost certain that the trend towards regional arrangements will accelerate. The establishment of such arrangements will necessarily intersect with efforts to ensure a more equitable distribution of global vaccine manufacturing capacity and create more resilient supply chains of critical inputs. And they may prompt regulatory consolidation as well, as they have in Africa, where the African Medicines Agency is just standing up. Finally, we have before us a moment of unprecedented political will to address the threat of epidemic and pandemic disease with the seriousness that these threats warrant. Vaccine development and the globalization of vaccine manufacturing and new vaccine technology will be central to any solution that is proposed. This will be a new global priority from which you, as manufacturers, certainly stand to benefit, but which will also call on you to exhibit leadership. I would offer a word of caution. If we don't move quickly, this window of opportunity will close, as we are beset by the new crises we can anticipate given the accelerating effects of climate change, current political polarization in many countries, and economic instability. We must take advantage of this window to secure critical resources and commitments while we can, before elected officials are distracted by other seemingly more pressing concerns. Peter Sands reminds us that pandemics have an odd way of falling off the priority list almost as soon as they are gone, when he refers to the recurrent cycles of panic and neglect. We cannot allow this to be the moral of the COVID pandemic. I will close here and merely point at the CEPI 2.0 agenda. You will hear from several of my colleagues over the next few days, particularly about our manufacturing initiatives. We've learned a lot from COVID and our response, and we have poured everything we've learned into planning for a safer, more inclusive, more just future. Thank you for having me in this opening session. Thank you for listening, and I wish you a very successful annual general meeting.
Thank you, Richard, for that excellent keynote address. I think your points about product development and R&D and large-scale manufacturing, where there is a lot of hope that is resting on the shoulders of DCVM and DCVMN manufacturers, is true, and it is well taken. We do recognize that hope that is placed on us, and many of the manufacturers and product developers in our network are working hard to ensure that we either scale up large-scale manufacturing and have vaccines and products available at the earliest. And we have done this through partnerships within DCVMN members, between innovators and manufacturers, and from IFPMA members transferring technology to several of the DCVMN members, and us manufacturing it at scale. I think these concepts are at the forefront of our thinking and our work ethic right now, and this will continue. Thank you. For my next speaker for the keynote address, I'd like to introduce Dr. David Caslow. David is part of PATH, and he heads product development and vaccines development at PATH. And to my knowledge and to my information, I can't think of a better person when it comes to vaccinology and to give us the cutting edge of what's happening around the world in terms of vaccinology. David, please.
Sai, thank you so much. And thank you to the DCVMN for the opportunity to contribute to, as Richard mentioned, this really aptly named annual general meeting that highlights new challenges, paradigms, and opportunities. If I might have my slides, what I'd like to do in the next 10 minutes or so is to share my thoughts on what a difference a pandemic should make. And I don't see the slides. Great. Thank you. Next slide, please. So as requested, I have no financial conflicts of interest to declare, but I do want to declare that the views and opinions expressed in this presentation do not necessarily reflect the views or opinions of others. Next slide. So we find ourselves in yet another crisis. And I really like this quote from Rahm Emanuel, who said, "You should never let a serious crisis go to waste. It's an opportunity to do things you think you could not do before." And for the DCVM and its members, I think this couldn't be any truer as the pandemic heads towards a third year. Next slide, please. So let me start by restating what has been repeatedly called out with respect to the new challenges that the COVID pandemic has brought and that is all of the people who have been left behind in this pandemic. Next slide. As we headed into the new decade at the 2019 annual general meeting in Rio de Janeiro, I presented this forecast which highlighted the projected vaccine doses needed between high and low and middle income countries, calling out a potential gap that could challenge the goal of Immunization Agenda 2030, which was to leave no one behind. Next slide, please. And if anything, as you've heard, the pandemic has widened, not narrowed that gap between high and low income countries, as shown in this infographic, demonstrating the disparity, at least in the percent of the population who's been vaccinated in low income countries compared to high income countries. And this is as of the 13th of October, 2021. Next slide. As you've heard from others, it's not just a gap in the vaccine supply and affordability between high and low income countries. It's also the cost of the healthcare systems in low income countries to deliver that vaccine. And as shown in this graphic, the difference in what it costs to vaccinate 70% of the population with a new vaccine. Next slide. So the new challenges for vaccine manufacturers is how we can address both the vaccine supply issues as well as reducing the burden on healthcare systems to deliver these vaccines so they do leave no one behind. And this means thinking about not just the cost of goods sold for the vaccine itself, but the inherent costs associated with delivering those vaccines from the factory floor to the hands of the vaccinators in the hardest to reach locations. Next slide. So turning to new paradigms, I'd like to mention two. Next slide. Before the pandemic, and again, from a presentation I made at the 2019 annual general meeting, Rio de Janeiro, I talked about these 4 business cases, and underlying all of these business cases was the assumption that vaccines were considered and managed largely as private goods. That is, in economic terms, they're rivalrous and excludable. Next slide. But as it's become clear that business as usual has failed to leave no one behind, the question has increasingly been asked as to whether or not vaccines should really be seen as public goods. And after much debate about the wording, the UN General Assembly just over a year ago adopted a resolution recognizing immunization against COVID-19 as a global public good. And clearly how one goes about manufacturing and procuring private goods is strikingly different than how one manufactures and procures public goods and services, for example, for national defense. So over the last 18 months, there's been a considerable debate about if and how vaccines should be managed as global public goods. Next slide. But to be clear, the old paradigm of 4 business cases will likely still exist. The question will be, in which business models are vaccines considered a private good, and in which business models are they seen more as public goods? And from a geographic perspective, who defines when a vaccine is a global public good or a regional public good or a national public good? Next slide. Another, and I think a final paradigm I'd like to highlight is related to the regulatory environment. Before the pandemic, for the most part, the regulatory environment for prophylactic vaccines adopted a precautionary principle, mainly because vaccines are administered to largely healthy individuals who individually have a very low risk of severe outcomes from infection. And this graphic on the right-hand side of the slide is adapted from a publication by Eichler et al. Back in 2013, and it highlights the likelihood of making a false positive regulatory decision on the extreme left and a false negative one on the extreme right. And as shown by the blue curve, to avoid all potential harm, one must become overly risk averse, likely leading to falsely rejecting vaccines that would in fact have a very favorable benefit risk profile. And on the opposite extreme, being insufficiently risk averse runs the risk of approving vaccines that bring more harm than benefit. Next slide. So in a perspective published at the end of last year by Steve Black et al., we propose that somewhere in the middle is the sweet spot that optimally balances the avoidance of potential harm with a maximal public health benefit, making the point that as we develop new vaccines and as they go through the regulatory process, we need to find that right balance between a high likelihood of a false positive regulatory decision and a high likelihood of a false negative regulatory decision. Next slide. The global vaccine pandemic has significantly changed that sweet spot for a variety of reasons, not the least of which are the urgent need for well-tolerated and effective vaccines, but also the application of the emergency use authorization or listing rather than the business as usual market approval or WHO pre-qualification. At first, the shift to the left was done quite cautiously before we knew whether or not vaccines against COVID-19 would be RSV-like and have the potential for antibody-mediated disease enhancement. However, as experience has grown with vaccine candidates and as the potential for a correlative protection has emerged, that curve has continued to shift to the left. Next slide, please. The question will be, post-COVID-19 vaccines, how far will that regulatory risk tolerance curve shift back to the right again? And I think there's an important opportunity for us to create a new norm, particularly if the manufacturers engage in continuing to assess the benefit risk profiles post-emergency use authorization and post-licensure, which means that the manufacturers really need to lean into actively generating real-world evidence post-licensure. And the more that we do that, the more likely regulators will share the risk in the initial approval process. Next slide. So in closing, a couple new opportunities and key takeaways. Next slide, please. First and foremost, the challenges in advancing health equity have never been greater. The gap between high resource and low resource settings continues to grow rather than close. The status quo paradigm of vaccines as private goods in low and middle income countries for public immunization programs has clearly failed to leave no one behind and seem more and more non-sustainable. And as we've discussed in the past, we need to continue to explore new paradigms of vaccine development, particularly for vaccines for the economically and socially excluded populations as either global, regional, or national public goods with the intent of really leaving no one behind. And finally, the COVID-19 pandemic has created some new paradigms in vaccine development, and emerging market vaccine manufacturers and the DCVMNs have an opportunity to make these new paradigms the new norm going forward. And with that, I thank you for your attention, and I'll turn it back to you, Sai.
Thanks, David, for that excellent overview of where I guess vaccine development is going and how we should think about some of these innovations in the days and weeks and months and years to come. I think for many of us in the DCVMN, we are living and working through this pandemic. There are problems in our own home countries. There are problems in several of the other low-income countries, and some of us are receiving technology, some of us are trying to innovate, some of us are trying to scale up manufacturing against all odds, if you can think about it, because if you think no manufacturer, whether it's in the developed world or in the developing world, had a ready-made set of facilities that were ready and available for COVID vaccines. So we're all in the process of repurposing new facilities that were constructed for another project or repurposing facilities that were designed for some other vaccine. And I think that thus far it has gone reasonably well. And I think it's a clarion call for all the other manufacturers to up the game a little bit and to try to manufacture more at scale. And I think we have to, as I said earlier, there is a big hope on the DCVMN. I think we have no option but to deliver. And we have to prove to the world that vaccines are a public good and it's not a private good or a social good, but we have to prove to the world that it is a public good. Thank you, David.
Thank you, Seth.
Thank you. With that, I'd like to take this opportunity to introduce Dr. Derek Sim. He is the Director of Vaccines Demand and Supply at Gavi. He comes with a lot of experience in vaccines introduction, especially with the introduction of Rotarix and Synflorix. With that, I'd request Dr. Sim to share his thoughts with us. Thank you.
Thank you, Mr. Prasad, and to the DCVMN for inviting me to give this keynote address. Vaccines have always been one of the best investments for governments and communities to promote strong health, social, and economic benefits, and they will continue to be into the future. When we look at the overarching awareness and demand for vaccines, this has been growing strongly over the last decade and will continue to do so. Given a couple of factors, some of which previous speakers have touched on already. Gavi and its alliance partners support currently vaccines against 17 infectious diseases through routine immunization programs, preventative campaigns, and emergency stockpiles. Even before the pandemic, by the end of 2019, Gavi had supported close to 500 routine introductions and campaigns and funded stockpiles of more than 135 vaccines. Increasing coverage has also been an aim by Gavi and its alliance partners across all vaccines, and countries have made significant strides in this. We can expect that the COVID-19 pandemic will accelerate the awareness of the benefits of investing in vaccines more generally to protect wider numbers of individuals and communities in order to ensure not only health, but societal and economic benefits. The DCVMN manufacturers have played an incredibly important role in supplying vaccines to meet this demand for vaccines and increasing coverage over the last decade. DCVMN manufacturers are now the sole suppliers of vaccines to Gavi-supported countries for vaccines such as typhoid conjugate, meningitis A conjugate, measles rubella, and Japanese encephalitis. From 2012 to 2020, over 50% of the vaccines supplied to Gavi-supported countries were from your companies, and that share is expected to increase. The investments that you are making into new, more complex and innovative vaccines, such as rotavirus, pneumococcal conjugate, oral cholera, will also increase supply security, give greater choice to countries, and improve the global market health. These are all critical as we move into an era spurred by the pandemic of greater demand and investments by countries in preventing diseases. In the COVID-19 pandemic, the DCVMN manufacturers are playing an important role, not only supporting the secondary production of vaccines, but accelerating tech transfers, which will definitely have a mid to longer term impact on the innovation, capabilities, and supply landscape of wider vaccines into the future. DCVMN companies have also demonstrated innovative platforms and ability to quickly turn innovations into vaccines that can be utilized. The example being the rapid development and deployment of the first DNA vaccine. We therefore expect that your ongoing investments, technology, and operational experience gained from these will impact the market health and supply of vaccines from which we can benefit in years to come. Looking ahead, we look forward to strengthening this partnership with you to meet the increased demand and also manage supply risks into the future. We count on your increasing reliability for the supply of all vaccines. Gavi has ambition to expand vaccination coverage into the future, and therefore the vaccine requirements will increase. Gavi and its alliance partners hope to reach zero-dose children ensure gender equity and vaccine access by all in the communities that we serve. This will translate into an increasing demand and reliance on DCVMN manufacturers to play a critical role in achieving these ambitions. There are new vaccines as well as we look forward into the future. Combination vaccines such as the hexavalent DTP vaccines will be incredibly important as we need to create greater space in vaccination calendars to accommodate other new vaccines such as the malaria vaccine and others in the years to come. While the pandemic has caused fluctuations in demand and supply over the last 18 months, and perhaps beyond in the short term, we strongly encourage the continued focus of your teams and your resources, investments, and capacities to ensure that more people in Gavi support countries can be vaccinated fully across all the existing routine vaccines, as well as bringing forward the new ones on the horizon in the midterm. This is incredibly important because, as we look forwards into the post-pandemic era, we see a renewed, I think, resurgence in the recognition of the value of vaccines, greater investments that countries, donors, and other stakeholders will make in this area. And we see that DCVMN will be an important partner in order to realize these ambitions as we move forward into the years ahead. Thank you.
Thank you, Derek. Thank you for your thoughts and for your vision. I fully agree with you. And, for many of the DCVMs, this pandemic has been a way to respond through knowledge sharing and learning. And also for many companies, this has set up a platform of a strategy of responses for future such events. Not that we expect any of that, but if there is a future such event, there is now a knowledge base that is readily available. There is a go-to toolkit that is available. And not just that, we can also deploy some of this knowledge and expertise to routine immunization, vaccines for routine immunization. And that's the excitement in the future that I see for many vaccine manufacturers and especially vaccine manufacturers in the DCVMN. Thank you very much for your thoughts. With that, I take this opportunity to introduce Dr. Samia Swaminathan. She's a chief scientist at the World Health Organization. She is a pediatrician by training and also is a leading researcher for TB and HIV. Prior to her tenure at the WHO, she was a Secretary of Health Research with the Government of India and also the Director General for the ICMR, the Indian Council of Medical Research. With that, I request Dr. Samia Swaminathan to share her thoughts with us. Thank you.
Thank you so much, Sai, and it's fantastic to be with you all, though virtually and not in person. And it's been a wonderful experience working with many of you over the last 21 months or so since we entered into the pandemic and have faced these challenges together. I think a lot has been said already in this opening session. We've had very, very rich inputs from a number of different people addressing all of the important issues around R&D, the need for scaling up vaccines, the role of the DCVM, the issues around equity and access. So I thought I don't have slides and I'll just share some thoughts with you on what lessons I think we've learned from this pandemic, which are relevant for all of us as we go forward. And clearly the DCVM plays a very critical and important role in providing vaccines and health products at scale, at the scale that's necessary to address these kind of global public health crises. But the DCVM alone cannot meet this type of a challenge. So I just want to take a step back to look at what kind of ecosystem, what kind of environment do we need at the global level, at the regional level, at the national level, in order to address not just this pandemic and future pandemics, but also how can we learn these lessons to take them to address some of our other public health challenges. Earlier today, I was speaking at the opening of the International Union Against TB and Lung Diseases, and it was very sobering to note that for the first time in decades, we've seen an increase in TB-related mortality, both. So we have a 1.5 million deaths now from TB in 2020. This has increased since 2019. And we also have a significant reduction in the number of notified cases of TB. So it's gone from 7.1 million in 2019 to 5.8 million notified cases. And we know that this is because of a variety of reasons during the pandemic, both lack of access to healthcare, as well as the inability of health systems to be able to cope with the pandemic and with essential health services. And the reason also that I think this is relevant is that TB is a chronic public health problem. It kills 1.5 million people every year. It has been doing so for decades. And yet investments in R&D on new TB vaccines, for example, are a fraction of what went into COVID R&D. If you look at TB investments for R&D, it was something like 0.9 billion. Of the total ask was only $2 billion a year. And even that was not met. So, and if you look at what investment would have gone into COVID vaccines, it would be at least 20 times that amount in 1 year. So this really begs the question as to who defines the priorities, who sets the priorities for global public health, and how are these taken forward. And this is actually at the very heart of WHO's work, and our strategic 5-year plan really addresses the goals, which are very well aligned with the SDG goals. And again, as everybody knows, what has happened because of the pandemic is that we've fallen back on all of the targets for the SDGs, and it's very unlikely if we continue at this pace that we will achieve those goals, either infectious diseases or non-communicable diseases, or around education, poverty, undernutrition, gender equality, etc. The pandemic has set us back in practically every SDG goal. And the link here to DCVM is around innovation and how can we bring innovations to really address some of these gaps. And again, vaccines are only one tool that we have. We will have to use many, but vaccines are a very important tool. And as was said by David Caslow, there is a great deal to be said for vaccines being a global public good. And I think this has been articulated many times in this over the last 18 months or so, but we really need to put that into action. What do we mean when we say that vaccines are a global public good? Because the knowledge, the innovation comes from ideas, usually in the academic sector, researchers who are funded by governments. And then this is translated. The innovation then gets translated, validated, scaled, etc., by private industry. And then it's again used for the public to usually to prevent diseases. What we've seen also from the new technologies, and Richard Hatchett and others spoke to this, is the unprecedented innovations that have happened during the last 21 months. And we've seen all of these new platforms, which of course have been, in laboratories undergoing some kind of piloting, but we had not imagined that we would have so many different platforms of vaccines. And the WHO has been tracking these right from day one. And it's absolutely amazing to see that you have 250 different candidates, over 100 of them currently in clinical development, about 35, 40 of them, in phase 3 trials. And of course, we already have a number of approved vaccines, and some of the platforms like mRNA, the chimp adenoviral vector, the DNA platform, some of the vaccine-like particles and others, nano formulations are all really undergoing a proof of principle at a scale that, really establishes their efficacy and safety. And the third element is the manufacturing. How easy is it to manufacture? How easy is it to scale? And how affordable is it? So this ultimately, I think, over the next year or so, we will probably see that when we have so many different types of platforms, which are different in the cost of goods, they are different in the ability to scale, they are also different in the ability to elicit immune responses. Some of them will do better with cell-mediated, some with humoral immunity. And we are understanding so much more about immunology of this virus. Again, unprecedented research for this virus, as opposed to many of the previous viruses that have been around for a long time, and yet we understand SARS-CoV-2 immunology, host responses, so much better. And this is going to also help us design studies, in the future for how do we evaluate the impact at a population level of using vaccines. Everybody now knows the term herd immunity. People are confused about herd immunity, but at least these concepts of clinical trials, of what is it to emergency use listing of a vaccine, what does it mean? What does it mean to have a policy guidance? What is emergency use and pre-qualification? And all of this is now being played out in the media, in the front pages of newspapers and television screens. And what it's done, I think the good side is to create a much better appreciation amongst people for the science that goes into vaccine development or development of health products, into what it takes, into the phases of development, and hopefully will result in a positive residual impact after the pandemic, where the public as well as governments and political leaders appreciate that you need sustained investments in R&D, sustained investments in clinical trial capacity. If you do not have that built up before a pandemic, before an emergency, you cannot put it in place within a few days. So countries that had that, made those investments, were able to very quickly pull all of those resources together and launch clinical trial platforms. One of the reasons why WHO launched the solidarity trial platforms was to provide an opportunity for developers of drugs and vaccines, whether they are small or they're big, to be able to test their vaccines and drugs on a platform that was multi-country, multi-centric, that was testing all of the products against a common control group, and which would result in results very quickly, relatively, compared to every developer doing their own clinical trial, and would provide data to the policymakers for quick policy decisions, because we know that without data, it's very difficult to go forward on that. So the point that I'm trying to make is that you need, I think, a rethink now at the global level that we've been doing at the WHO as to what kind of facilitation can we provide, what kind of solutions. And what we did was to have the target product profiles for the vaccine for COVID out in the public domain in March of 2020. This allowed manufacturers around the world to have a benchmark against which they could assess their vaccine, and it was accepted by all regulatory agencies. So that is an example of a key WHO function around norms and standards, of defining what the standards are, defining what the benchmarks are, and also bringing together through the R&D blueprint, we were able to bring together, and we continue to discuss topics like booster doses, what is the science behind it, comparability studies, bringing together scientists, regulators, policymakers, in order to advance some of these ideas and come up with some common agreement on the way forward. So you need investments in clinical research capability, ethics review and oversight. Regulatory agencies also all had to work at super fast speed, both to approve, regulate clinical trials, but also to then regulate the products. And it required, again, WHO, and you will hear more about how we work with regulators around the world, also to harmonize the requirements so that the approvals in country could also happen very quickly after WHO provided the emergency use listing. And then finally, I think we need to think about for the future, not just focusing on vaccines for infectious diseases, but these new platforms and technologies have now provided us opportunities and scope to think about vaccines for cancer. For example, we know that there are mRNA vaccines in development. And one of the reasons why we started with mRNA technology when we set up the Tech Transfer Hub, and it's a global tech transfer hub that we've set up in South Africa. So any country, any company interested in coming and learning the mRNA technology and going back is welcome to do so. This will become operational from early 2022. And the idea really is that mRNA technology today offers us huge potential and scope beyond infectious diseases. So we hope that some of the steps that we've taken now will help to make these products a global public good, but of course it's going to require also the political support and very importantly, the financing in order to keep these the manufacturers, especially the new ones that are coming up now, to be sustainable and to be able to deliver vaccines, not just against COVID, but other infectious diseases and non-infectious diseases in the future. So I think the opportunities are immense. We've learned a lot from this pandemic, and I think it's up to all of us to take these learnings forward in order to improve public health. Thank you very much, Sai.
Thank you, Dr. Swaminathan, for that eloquent address. I think you've touched upon a series of important points, targets and goals. And I think if you look at the pandemic, the WHO, people like yourself and many other international agencies and governments set the targets and goals, including the target product profiles. And I would say industry in the developed world and in the developing world have responded. I mean, in terms of knowledge and technology and science and manufacturing. Obviously, we need to do more in terms of the scale of manufacturing and having more vaccines available. That is a work in process for many of us. But I think innovation and the product development activities that we have learned and the scale up of manufacturing, how to do rapid scale up that we have done, I think that's real, and that can be translated to other problems and other disease models. And you mentioned TB. I think if the targets are set and if the goals are set, I am very confident that companies can stand up and respond to them in the years to come. And I think that is what we have learned from this pandemic. And I think we need to deploy that more actively against not just other endemic vaccines or pandemic vaccines, but also for vaccines for routine immunization. I think so. Thank you very much for that. And we will continue to do this work. With that, I would like to introduce Dr. Solomon Zueidou. He's a Deputy Director for Health and Nutrition for Africa at the Gates Foundation, Bill and Melinda Gates Foundation. He oversees the foundation's health and health-related investments in the continent. He's also been a part of the foundation's COVID-19 pandemic response coordinator for Africa. Without further ado, I'd like to have him share his thoughts with us. Thank you.
Thank you, Sai. I'm the fortunate one here, I think, in a sense that I am sitting in Cape Town, thanks to the kids. Thanks to the kids' spring break. So in fact, I'm looking at my hotel room and I'm seeing the tabletop, the Table Mountain, very clear and beautiful weather, just like Mrna was saying. So it is really delightful for me to be here, and in addition to the conference. That being said, I would love to acknowledge all that has been said already. And in that note, there isn't much left, so I'll be very brief, and I'll make sure that I kind of center my conversation more around the paradigm and the opportunities. Because so much of the massive challenges that COVID has presented to us has already been quite eloquently described. We all recognize that the developing countries, and especially Africa as a continent, is no stranger to vaccine manufacturing practices. Rather, it is a stranger to the sustainable ecosystem that was just mentioned by my colleague prior to me, that makes manufactured vaccines effectively contribute to the global and continental needs. Across Africa, we see in the north, the east, the west, the south, that countries have already been able to successfully produce vaccines over decades. And we're not here just for the fact of talk about manufacturing abilities. Today's opportunity isn't about flooding the developing countries with manufacturing plants that will never live up to the expectation, the effort, and the finances that went into it. Rather, the certainty of creating the right ecosystem that assures the success of these existing plants or any additional ones that can organically form in the future, and emphasize and beyond this pandemic situation. An opportunity to give manufacturers in developing countries a unique and genuine chance of effectively contributing to the global manufacturers' pools and supply these life-saving commodities, which the continent is the biggest consumer of. A colleague prior to me mentioned the fact that it shouldn't be about COVID, it should be about all communicable diseases. We have heard of it, that there have been the stark references to Africa producing only 1% of all of the vaccine it administers, as well as being the continent with one of the highest communicable burden in the world. When COVID came to Africa, it did not arrive as a substitute for the other killers. It's been mentioned once again. It painfully complicated an already dire situation, which makes the need to find deeper and long-lasting situations even more critical. So we've been hearing over the past months the slogan around building back better as a direct consequence of the continent that has yet to recover for its health, economic, and livelihood crises. The last mention of this was during the African Union and the African CDC summit in April 2020 of 2021, 12 and 13, where this dire need was echoed again. But the question today isn't about how many more plants we should build, rather how much better it should be done to allow developing country manufacturers to effectively contribute to the global vaccine need and also control at least part of its population's destiny. COVID-19 has shown to us that COVID-19 vaccine access is strongly correlated with the locations where there is the R&D, vaccine R&D, as well as the manufacturing capacity. So one should question, with only 1% of all vaccines administered in the continent of Africa, how much of its faith is Africa really controlling at this particular moment? But we all know that vaccine manufacturing is also complex, but should not be confused with the fact that it's impossible. It is not impossible. That myth has been debunked, and manufacturing has been done for quite some time. So how do we all come together to make Africa manufacturing capacity relevant is the question and challenges we all need to solve collectively and as a global community. At the Bill and Melinda Gates Foundation, we appreciate this complexity, and our efforts have been in supporting the building blocks of an effective and sustainable ecosystem. That word has popped up once before with my colleagues prior to me. With all of our global partners, including developing country leaders and scientists. We look across the continuum of brokering solid partnership between the scientists, manufacturers, and decision makers of the North with the same in developing countries. We appreciate the need for solid and effective regulatory standards, platforms, and removing some of these barriers that developing countries currently look at so that they can interchangeably work with the rest of the global system. The critical need for human capital development and the investment of conducive environments for developing countries to retain the talent pool for greater performance and excellence on the continent, wherever continent these developing countries may be in. The creation of an effective market to appreciate the products and contribution of developing countries is also one. And I named just these few, realizing that there's a much broader context and a much broader ecosystem that needs to be developed. But what's very much encouraging is the representation on this panel, as well as the lineup of experts throughout the coming days as a testament of the commitment to start and finish this marathon of building back better, while leveraging the lessons learned from COVID is real. I would like to thank the organizers again, Sai, and everyone else that has come before me and throughout the next couple of days, and say that the Gates Foundation remains fully committed to the cause of building a sustainable ecosystem beyond pandemic situations where developing country manufacturers will effectively contribute to the global vaccine demand, whether it's COVID or non-COVID. Thank you very much.
Thank you. Thank you, Solomon. Thank you for taking time from your visit to with family to be with us. You know, we appreciate that. Your thoughts and words are important, and we and our constituency needs to hear that. I think I fully agree with you, and I can't agree with you any more about how an ecosystem is required. It's not just one company or one manufacturer that can do this. And that entity has to be sustainable in the long run. And if that has to be sustainable in the long run, you need an ecosystem. And what does that ecosystem entail? You need trained human capital, you need long-term procurement strategies, you need a good, strict regulatory environment, you need a stable political environment also, you need many aspects that are required to make a vaccine manufacturer successful. So I think this is vaccine manufacturing by itself is not complex. You rightfully said it's not impossible. It's very much possible. Many companies in our own network have proven that, but they've all done that based on other aspects of the ecosystem that are readily available, or they could make do for that lack thereof in many of the countries. I think that's very important. I'm glad that you brought up that topic. I think in the days to come, we also will be talking about this. Thank you so much. With that, I would like to introduce Dr. Rogerio Gaspar. He's the director of the Department of Regulation and Pre-Qualification at the WHO. As an academic for the last 36 years, he's got a lot of international experience and regulatory experience across the world. With that, I request Dr. Gaspar to share his thoughts with us. Thank you.
Thank you very much, Prasad. I will share the slide just to confirm if you are seeing my slides already on the screen. Can you confirm if you see the slides?
Yes, we can see them.
Yeah.
Thank you very much. So first of all, on my first address to the CVMN, since I took office here at WHO early this year, let me first thank the CVMN for its continued commitment in supporting the global effort to respond to the COVID-19 pandemic. And also taking the opportunity to address some of the lessons that were learned and looking into a future with increased collaboration and cooperation to find solutions for global health threats, ensuring global health security. I will go faster on the slides that I have prepared. I will share them with the organization to be appropriately disseminated. So the first point I would like to make is that reliance and regulatory reliance has been at the center of this crisis. Reliance helps to transfer the regulatory information from trusted sources to facilitate in-country approval. The World Health Assembly Resolution 6720 recognized that inefficient regulatory systems themselves can be a barrier to access to safe, effective, and quality medical products. So WHO pre-qualification and approval by stringent regulatory authorities provides a good basis for informed national registration, but in a manner that should be adapted and conform with a number of transparent principles. The main objectives are, though, to get the pre-qualified approved products to patients faster and more efficiently, as well as to ensure continued supply of quality assured products post-registration. The collaborative registration procedure is part of that endeavor, and when it started timidly. I have to say that currently, as of today, we have 45 national regulatory authorities and 1 regional economic community participating in what is the most successful part of the CRP, which is medicines. Unfortunately, we'll see that on vaccines, we have still some work to do, but I will address that subsequently. This is done, of course, using an instrument, which is a WHO instrument, applicable guidelines established by consensus among the technical experts, discussed with the national regulatory authorities, and public consultation with appropriate stakeholders. So since 2016, those sets of rules were clear for everybody, and we started an increased speed of introduction of the CRP. First on the medicines, and I have to say that on the medicines, it was a success both in terms of volume and also in terms of the days used for the assessment after submission. You can see that after 2016, the number of files increased significantly. And of course, because of the sheer volume of files being submitted, the delays in the approval was also evident. After that, you see a reduction, and even through the pandemic, with numbers that are of the same level as in precedent years, like in 2020, we were able to achieve 67 days as an average for a decision-making process on the medicine CRP at the national level. So 2021, this is not the final numbers. This is the interim numbers from mid of the year, and we'll be reporting soon on the final numbers for the year. So what about vaccines? So vaccines started even before 2016 with a number of discussions using the MAN-AfriVac as among other networks. And from 2016, as I exposed, the ECBS standards and guidelines were endorsed and implemented. There are 44 participating NRAs and 1 regional community. I have to say that we still need confirmation and submitted of CRP agreements for a number of countries that are disclosed here on the slide. But even though we were able, during those years between 2016 and end of 2019, early 2020, to proceed with a number of registration for vaccines using the CRP. What changed meanwhile is that we had COVID-19, and COVID-19 had 2 impacts. One was a negative impact in continuation of the CRP. The other one was the positive impact in the redesigning and preparing the regulatory system for a more agile and quick response. And this is an example for the SII on AstraZeneca technologies. You can see that with a double of the registrations in the month of September, we have currently, as of today, 503 registrations completed in 122 countries through the EUL process. So this shows that vaccines can do it as well as medicines. We were able to do it through the very stringent environment of the pandemic and the emergency use listing. So it's potentially also useful to learn some of the lessons. This is another example. This is for the US government donations for a number of other vaccines. And you see these numbers, 71 countries, including 39 countries in Africa, with the registration completed right now, and as of 30th September. Well, how was it possible? So it was possible mainly through an intense collaboration between the different stakeholders. And I have to say that I will not go into the details, but in this slide, because it's too condensed with information, but I would say that what happened inside COVAX, that was already referred by several, what happened between the scientific, industrial, and regulatory community, but at the same time, the political will to provide access to information that previously was not available. Room for improvement? Certainly. Even in a country like the US, and recently 2 weeks ago, we had an extraordinary workshop, 2 days workshop from the National Academy of Sciences, Engineering and Medicine, looking at the emergency use authorization from the FDA. It was able to identify several points for improvement, including changes on the confidentiality legislation in the US. This is something that is not particular to the US. It's also a question that we are dealing with different member states and national regulatory authorities, making sure that in the near future, we'll have better instruments to share all the information, including vital information among regulatory authorities that are not related specifically only with the products, but also with the oversight of the manufacturing capacity, like inspection reports that are not redacted, that can be freely shared between regulatory authorities. We are working on all those files in order to make this process even more efficient. This is a map of what was done and accomplished since the beginning of the pandemic. with the UL on those yellow bars in the middle, with several of the emergency use listing that were already given. For all those products, we are now experiencing an explosion on post-approval changes, as it would be expected, with better stability profiles, with changes in packaging, changes in formulation, better distribution capacity. So all these changes are also bringing a huge volume of regulatory work that is shared between WHO and member states, but also some lessons learned on agile ways of interacting between the national regulatory agencies, authorities, and WHO and manufacturers are valuable information for the upcoming period and for a full implementation of the CRP in vaccines, as we did for medicines. This is the current situation for the 13 UL listed vaccines, 8 rolling submissions already initiated, 5 vaccines more planned on the pipeline, and the numbers are growing. Critical issues for the CRP and vaccines that we should not avoid to discuss. First of all, CRP is one of the reliance tools that has been proven to be effective in facilitating access to medical products, including vaccines, at the national level. We are all committed to support it. Because of the complexity of vaccines and unique benefit risk scenarios related to their use when compared to medicines, in addition to sharing reports, there is a need to explain the contents and rationale of the decisions made, and we have available to respond to any technical questions from the countries that may arise as the national regulatory authorities make the benefit risk analysis, and this also in the context of vaccine policies, which are out of the scope of the regulatory framework. This comes with the need of more resources to be shared and to be intensively used. The market structure of vaccines, with fewer manufacturers participating in public tenders for distribution through the public sector, is not adequately tuned to some of the national requirements either, like the need of local technical representative in each country. This tends to reduce the uptake of the CRP and national registration for vaccines in general, especially in small markets. Manufacturers and national regulatory authorities should work together to find innovative options to overcome these challenges, so as to increase the uptake of the CRP and not to prevent access. Acceptance of a regional representative could be considered as one of the solutions. And the experience from COVID-19 has shown that innovation and flexibilities, both from manufacturers and national regulatory authorities, with an appropriate facilitation from WHO and other stakeholders, could facilitate quick access to much needed products. Whereas some of the practices and flexibilities cannot be sustained outside the pandemic, some lessons could be beneficial during normal times. So, considering a number of recommendations that we were challenged, I have to say that after a period negatively impacted by the pandemic, it is now time to establish a new common effort on the CRP of vaccines, bringing together all stakeholders. The lessons learned during the pandemic and the well-established relationship between WHO and more than 100 countries in guaranteeing access to vaccines in low and medium income countries provides the opportunity that cannot be missed. In that regard, we will be convening a meeting with different stakeholders for Q1 2022 in order to agree in fast action items that can bring to CRP or vaccines the extraordinary good collaboration accomplished during the UL of COVID-19 vaccines. Finally, just a word of full commitment to the use of the 3 axes of our department: pre-qualification, regulation and safety, and local production assistance in a comprehensive manner, listening and engaging with the stakeholders at the service of public health and supporting member states, including the entire health ecosystem that needs a strong manufacturing capacity. I think I was within the 10 minutes allocated. Thank you very much. And I'll be sharing the slides with the organization for further dissemination. Over to you.
Thank you, Dr. Gaspard, for that excellent overview. There is a lot of issues, like you mentioned, regarding the CRP and EUL. I think the lessons, what we are learning from EUL and how countries are accepting the guidance from WHO on EUL could also be translated to the CRP procedure, I think. And in vaccines, I think it has a role to play. I know that many DCVMs are struggling with regulatory approvals in countries, even after WHO pre-qualification. It's taking an extraordinary amount of time time. We know that for a fact, but I look forward to that meeting in the first quarter of 2022. I think you will get a lot of input and feedback from the DCVMs. Thank you so much.
Thank you.
Thank you. With that, I'd like to call this session for a close. I request you to join the next session, which is already just getting started. Thank you.